Good afternoon, everybody. I'm very thankful to the organizing committee for this nice virtual conference. Our talk today is about oral cancer management at the time of COVID pandemic, and I will share you my experience in my hospital, Ghazi Al-Hariri Hospital in Baghdad. We all know that at the 11th of March this year, the World Health Organization declared COVID-19 as a pandemic. And at that time, the Director General of the WHO made a big statement. He said that it will be a public health crisis that will touch every sector. And actually it was. Soon after that, we find our Earth is surrounded by that virus. Actually, it was invaded by that virus. And all the world goes into a lockdown. Everybody was in quarantine and we don't know what to do actually at that time. It was the time of coronavirus horror. The decisions was reactionary, not strategic. There was a crisis in every sector of life, and after that we start to learn from the disease. We start to learn how to manage those issues, and we transferred from coronavirus horror to COVID-19 disease, as we will talk through this lecture. So what is COVID-19? It is the disease caused by SARS-CoV-2 virus, severe acute respiratory syndrome coronavirus 2, as to SARS virus that affect China at 2002 and 3. What is the pathophysiology? We know that the alveoli of the lung composed of two types of cell, type 1, which is very thin to permit perfusion of gases, and type 2 cell, which is responsible for production of the fluid as a surfactant. The virus has a spike protein that attaches to the wall of type 2 alveolar cell and goes into that cell. What happened? It will destroy the cell and there will be activation of the immune system. That activation of the immune system will lead to a much more destruction of the cells and fluid accumulation. At the end of the story, we will lose that functional respiratory unit by fibrosis and by accumulation of a fluid that will subject the patient to a secondary bacterial infection. Not just that, we have other issues. Coronavirus may hit the lung, not hitting only the lung. It may hit the heart, the brain, the GIT, the renal system, and patient may die not only from hypoxia. A lot of deaths are known after hypoxia. It was due to micro or macro thrombosis or overdrive of the immune system, and that will lead to multiple organ failures. Talking about death, the case fatality rate of this disease was so high, it was registered to be 3 to 4%. But look into that number, it comes from the number of reported deaths over the number of reported cases. And we know all over the globe that the number of actual cases is much more than the number of reported cases. So that number will be diluted. Some authorities think that it should be 0.5% only. And we knew that death is concentrated in the upper age group, while it is 0.2% in the child and young man. It will be about 15% in 80 plus person. So what about transmission? There is a lot of talk and controversies and media and everything about the transmission. Whether it is droplet-borne, whether it is airborne. The talk about the size of the droplet. Is the droplet is big enough? It will rest on the nerve-boring surface that will cause take the virus to other areas. If it is small enough, it will circulate in the air and goes to the lung of another patient. At the end of the story, it is a highly contagious disease. We know that from the Arnold. Each person can infect 2.5 persons. After that cascade, in 1 month, only 1 month, one patient can cause infection to more than 400 patients. That has a serious application in our job actually. Tracking the occupational risk score of COVID-19, we see that healthcare professionals are much subjected to infection than other professionals. And at the top of the professions are the dentists and dental assistants and practitioners, family and general practitioners. And that's because of two important. The first, we know this chart. If the doctor or healthcare worker and the patient kept his mask, the infection rate is about 1.5%. But what we do as dentist, as a maxillofacial surgeon, as ENT specialist, as anesthesiologist, as we tell the patient to get his mask off. That will increase the infection rate to 70%. Another thing we do is the aerosol generating procedure. All that procedure that was relatively safe now become very, very unsafe. Tracheostomy, surgical airway management, dental procedure, induction of anesthesia, high-speed turbine, any things that even high-pressure ventilation will cause aerosol generation, and that aerosol will take the virus along the room and for a far distances. So, how can we protect ourselves from the aerosol? First, I checked the guideline, the NHS, CDC, WHO. They talk about the N95 respirator and the FFP3 respirator. The Chinese, on the other hand, talk about the PAPR. So here is the handbook, early publication of a handbook about coronavirus. It comes from Wuhan. They make 3 levels of protection. The aerosol generating procedure lies in the highest level of protection, where the PAPR is. The PAPR is the powered air purifying respirator. Here is a HEPA filter, and there is a motor that brings the air through that filter to the hood that will supply fresh purified air to the healthcare worker. Along with that, we need eye protection, and also we need droplet or splash resistant gowns. Going to the other part of my lecture is the impact of COVID-19 on the healthcare system. Actually, what happened that COVID-19 opened our eyes to our deficiencies, not just in Iraq, all over the globe. The healthcare systems were not prepared for such a pandemic, and that is important for the future to invest more in the healthcare system and invest both in infrastructure and in the manpower of the healthcare system. One of the things that should be said is the salary. The salary of the nurse here, you can see, is lower than the salary of the train driver, and it is nothing to the salary of the football player. One of the important things to talk about is the impact of COVID-19 on healthcare workers, both physical and beyond physical, the psychological impact. For example, in March 2020, 1 per each 4 doctors in the UK were off, either sick from coronavirus or in isolation or caring for a relative sick of COVID-19. A study from Singapore showed there is a high level of anxiety, depression, and stress in healthcare workers dealing with COVID patients. Actually, there was a documentation of a case of suicide. A nurse in Italy, ICU nurse in Italy, suicided due to increased level of depression and anxiety. Beyond that is the death. There was death all over the globe of healthcare workers, Amnesty stated that there is 7,000 deaths of COVID-19 in the healthcare worker, and due to that, the people start to appreciate the selfless, courageous act of the healthcare worker, where they face that disease by themselves. In Iraq, we have our share of that death. Here is our senior anesthesiologist in our hospital, chief pediatrician, chief rheumatologist. Not only the old age group, even the young nurses are subjected to die from that disease. Talking about epidemiology, Johns Hopkins updates us daily with the numbers of COVID-19. The global number is exceeding 26 millions, and we will soon reach the 1 million death of COVID-19. In Iraq, the first recorded case was at the end of February in Najaf. The first mortality was at the beginning of March in Sulaimaniya, and after June, the number climbing very sharply. It may be due to release of the lockdown, and it may be due to an increase in the number of tests. And here is the updated numbers in Iraq, and we exceed the 4,000 cases per day, new diagnostic cases. Here is the dashboard of Iraq and the WHO website, very informative. Here is the website if you are interested. Talking to the second part of my lecture is about oral cancer. We know that over 500,000 cases per year are diagnosed with oral cancer, and actually it is a lethal disease. The 5-year survival rate is 40%, and we can change that number to 90% survival by early detection. Early detection mean not just early detection, it's active and early intervention. And that was the core of that paper in oral oncology. He stated that we cannot wait for this pandemic to end. Simply, we cannot wait. So, what to do? You can see that for stage 1 cancer, the 5-year survival rate is in 80s. For stage 4 cancer, the 5-year survival rate is in 30s. So if we wait, those cases will be transferred from stage 1 to stage 4, and the survival rate will much more decreased. And that is a good message to my dental colleague, actually, that early detection saves life. And that is the role of oral cancer screening that should be done by every dental professional. I ask you to look for ulcers, patches, lumps during routine dental examination. And as a rule of the thumb, any ulcer that do not show signs of healing after 2 weeks, it should be biopsied. As a professional dealing with cancer, such as radiation oncologist, medical oncologist, surgical oncologist, we have guidelines. For example, this is the NCCN guidelines. It's updated version 2020. It does not talk much about COVID-19, but at the early time of the crisis, we want a protocol. We want something to guide us what to do in that time of pandemic, because nobody knows what to do. And at that time, the Royal College set a series of webinars to shed the light on how cancer should be managed all over the world. And there was a lot of controversy, a lot of confliction. People were managing cancer in different ways, not over the globe, even across units in the UK. There were conflicting recommendations between the Royal College of Surgeons and the Public Health England, and the sky was very cloudy, the road was not clear. With time, bodies start to update their recommendations and guidelines, and things become more and more clear. COVID surge, I recommend you to search this website. There is a lot of evidence-based material in that, and papers coming from literature start to clarify the situation. As a rule of thumb, it is contraindicated to do surgery for COVID-positive patients. I mean non-urgent surgery, not emergency surgery. Why? Not only just to protect the healthcare worker and to prevent the spread of the disease, but for the sake of the patient. For example, if we do surgery for COVID-positive patients, half of them will have serious pulmonary complication. 1 in 4 will die from such a disease or from COVID-19. What makes the situation dilemmatic is how do we know that our patient is COVID negative? We usually do PCR. PCR is very specific, but it is not sensitive enough. And you can see in this paper, PCR sensitivity is highest at 3 days after symptoms, and it is 80%, not 20%. So how I know that my patient is asymptomatic carrier and his result is false negative? What makes it more dilemmatic is the antibody test. And we know there is a time gap from this graph between the infection and the start of appearance of immunoglobulin in the body. And there is always a 20% false negative cases. Talking about the CT, chest CT, chest CT specialists talk about that this ground glass appearance is not specific for COVID-19, and that makes the dilemma and will stay dilemma. And the only thing I can tell you, it will be a risk. Whatever you do, there will be a risk. So, what is the protocol? I will not discuss various protocols. I will discuss the protocol that we use in our hospital. First, it is a surgical hospital, so it is non-COVID hospital. We screen all patients for COVID-19 by PCR. We managed to make a special social media group for the physicians and anesthesiologists and the residents. So the information will circulate rapidly. COVID negative patient will be treated as fast as possible, not to contact the disease, and COVID positive cases will be isolated and transferred as fast as possible with a special protocol. We postponed all elective cases to decrease the number of patients in the hospital, to decrease the cross infection and decrease the complication. We mandate PPE for all staff in the hospital. I mean, all is all. Everybody in the hospital should wear a gown, gloves, mask, head cap, cover shoes, and protective eyewear. From the ward, from the ER, from the consultation clinic, even in the administrative areas. But you know there is issues with compliance. 50% of the work staff will attend and 50% will not. We kept them as a safety. If somebody get infected, we will have a cover and will not have a collapse. Education. I personally was involved with that part of the procedure because at that time Corona was a horror, and I try my best to make it a disease with numbers, with the morbidity, with the mortality, not a horror. And we reinforce the infection control measures. Sodium hypochlorite was used for the general cleaning of the floors, and the WHOs and the WCs of the hospital twice a day, and quaternary ammonium compound disinfectant were used for all other surfaces in the hospital. We raised a campaign for hand hygiene control, hand hygiene, and also there was a problem with the compliance. We do two special things actually in our hospital. There was a severe shortage in the coverall. We use the coverall for suspected and positive coronavirus cases. At that time there was not available, and we arranged with local protection facility to make us those coverall. And also we involve the patient and relative with the infection control measure. Here you can see we distribute that bottle of water to every patient so he can disinfect the surfaces around him, the doorknobs and the WCs. Now we shift to the clinical cases, and I beg your pardon, there will be blood, and you know cancer surgery is a bloody surgery. My first case is a 40 years old man. He has actually a big disease. He has squamous cell carcinoma of the mandible with involvement of the submandibular lymph node extruding through the skin. PET scan showed us that he does not have distant metastasis, and we can operate on that patient. So a big resection, the mandible with associated structures that involve the tumor, and classical radical neck dissection. We almost remove everything from the neck except the carotid and vagus nerve. And we need a big reconstruction for this big resection, and that was the cause we used the major mycutaneous flap. And actually these cases are treated by free flap elsewhere in the world, but now at the time of COVID the recommendation is to omit free flap and concentrate on the local and regional and medical flaps. Fortunately, he still had a very functional hand despite we removed the pectoralis major and despite we sacrificed the spinal accessory nerve. My second case was in April. She referred to us from ENT specialist. She has adenoid cystic carcinoma at the posterior part of the maxillary sinus, which is a very nasty area, and you can see here is the telangiectasia at the palate, which is a very nasty sign if you see it on the mucosa or on the skin. So we prepare a surgical stent, and you know impression is an aerosol generating procedure, oral surgery is aerosol generating procedure, and we have to take that risk. Maxillectomy, and thanks to our prosthodontist who construct a nice obturator that make the patient talk and swallow food comfortably. On May, we have this man with advanced squamous cell carcinoma of the tongue. All the tongue was indurated and fixed due to that tumor, and we're gonna need a big reconstruction by thick major flap. We advocate the compartmental tongue surgery as a big talk. It is a lecture by itself. The idea is to resect all the tongue, the floor of the mouth, and the associated suprahollow muscle along with the neck dissection to prevent local recurrence, especially in the lingual lymph nodes. After
احسب لي من 1 إلى 10.
1 2 3 4 5 6 7 8 9 10.
مش عجبي وقع هيك. سيطر عليه.
That smile of the patient is give us actually our energy. You see that his neo-tongue is functional from a speaking point of view and from a swallowing point of view. Another case which was very dilemmatic at that time, it is adenoid cystic carcinoma of an ulcer in the tongue and a nodule in the lung. And after detailed and long discussion in the MDT panel, we reached the decision that we should do local resection of the tongue and metastectomy to the pulmonary lesion, and she survived well. That was at May. At June, we have another chap with advanced squamous cell carcinoma of the floor of the mouth. The induration goes along the tongue, all of the tongue, So we do another compartmental resection. We remove all of the tongue, the floor of the mouth, part of the mandible, and all the suprahyoid muscle along with the neck dissection. We need a reconstruction. We made a new tongue from this pectoralis major flap, and that new tongue actually was very functional. He talked comprehensively and he can swallow effectively. And that smile again is our fuel. In July, we have this man. He has delayed management due to problem with his systemic condition. He has a problem with the heart and hypertension. After controlling his disease, which was not easy for this non-compliant patient, we goes to the theater to do radical parodontictomy and reconstruct the area with the skin flap from the neck and the chest wall. And cases continues. Here is a case with the squamous cell carcinoma of the nose, one surgery for resection, other surgery for reconstruction, adenoid cystic carcinoma of the parotid, cancer, always cancer of the tongue. Here is a guy that I treated 2 weeks ago. He has a big squamous cell carcinoma of the mandible. He's a 77 years old man. He was well recovered. When he goes to home, he catch COVID-19. Now he returned back to hospital and his saturation is decreased, and I don't know he will make it or not. Just last day we do some resection for this squamous cell carcinoma of the tongue along with neck dissection. And cancer cases continue, and we have to treat them because delaying their management meaning decreasing their chances of survival. As a conclusion, always I say there is a coronavirus horror versus a COVID-19 disease. We should think with COVID-19 disease as a disease. We should be rational. We should manage. Cancer cannot wait, and we have to take the risk. And my last word is stay safe. Thank you.